Diabetic foot is one of the most common and serious complications of diabetes mellitus. It refers to any pathology that affects the feet in diabetics. It is caused by damage to the nerves and blood vessels as a result of high blood sugar levels associated with diabetes. If left untreated, diabetic foot can lead to infections, ulcers, gangrene, and ultimately amputation. Thus, early identification and management of risk factors is crucial in preventing progression of the disease. The high blood sugar levels associated with diabetes often lead to two key complications that contribute to diabetic foot: peripheral neuropathy and peripheral arterial disease. Peripheral neuropathy. Prolonged exposure to hyperglycemia can cause neuropathy, which is damage to the peripheral nerves. The nerves become unable to properly transmit signals, resulting in a loss of protective sensation. This means diabetics cannot accurately feel touch, temperature, vibration, or pain stimuli. As a result, minor injuries can go unnoticed and develop into more serious foot problems like ulcers and infections. Nerve damage also leads to changes in foot structure and deformities. Peripheral arterial disease. Hyperglycemia also damages blood vessels, restricting blood flow to the extremities like the feet. This reduction in blood circulation impairs wound healing, making it difficult for even minor cuts and abrasions to mend. The diminished blood flow also starves tissues of oxygen and nutrients. This makes the feet more susceptible to infections. If left untreated, it can progress to critical limb ischemia, which can have serious implications like gangrene, ulcers, and amputation. There are other diabetes-related factors that raise chances of diabetic foot complications like blindness, kidney disease, obesity, and smoking. Risk factors include poor blood sugar control with consistently high HbA1c levels, long-standing diabetes, peripheral neuropathy, history of foot numbness, tingling, loss of protective sensation, peripheral vascular disease, previous claudication, absent foot pulses, foot deformities like bunions, hammer toes, etc., visual impairment, diabetic nephropathy, kidney disease, previous history of ulcers or amputation, peripheral edema, smoking, obesity. Classification. Once tissue damage has occurred, diabetic feet are generally classified according to the depth of the lesion and extent of tissue loss. Diabetic foot ulcer, ischemic diabetic foot, neuroischemic diabetic foot, Charcot foot, diabetic foot infections. Diagnosis. Early diagnosis allows for prompt treatment, preventing progression to disastrous outcomes like amputation. When evaluating feet, both sensations as well as vascular function should be assessed. Some key aspects include history, physical examination, investigations. Treatment is aimed at preventing the condition from worsening, heal existing wounds, and preserve lymph life. It involves strict glycemic control, offloading footwear modifications, debridement, antibiotics, revascularization procedures, hyperbaric oxygen therapy, amputation. Preventative measures like patient education, routine inspection of feet, and appropriate foot care practices are crucial. These include wearing well-fitted shoes, avoiding walking barefoot, daily cleaning and moisturizing feet and legs, regular filing of calluses, prompt treatment for any wounds, infections, and quitting smoking. Those at high risk may also consider referral to a podiatrist. Here are some examples of patients with diabetic foot complications. Case 1. John is a 35-year-old architect diagnosed with type 1 diabetes at age 15. Despite insulin therapy, he has chronically high HbA1c around 10%. He enjoys jogging daily. Recently, he developed a blister on his right heel that he ignored. He now presents with a large ulcer on the heel, surrounded by redness, and his foot is swollen and painful to touch. He is diagnosed with a deep plantar wound infection and cellulitis. He is admitted, started on intravenous antibiotics, and the ulcer is debrided. A total contact cast is applied, taking pressure off the site, enabling it to heal after 3 weeks. Case 2. Mary is a 62-year-old banker with poorly controlled type 2 diabetes and diabetic kidney disease. She has a history of numbness and tingling in her feet, but refused to go to a podiatrist. One day she steps on a sewing needle but does not feel anything unusual. She notices a minor cut, which then gets bigger despite her applying antibiotics. Within days, it becomes an infected ulcer extending to the bone. She undergoes surgical debridement and drainage, followed by 6 weeks of intravenous antibiotics. Thankfully, it healed well, but it resulted in a prolonged hospital stay. Case 3. Raj is a 45-year diabetic struggling with diabetic neuropathy and smoking. One day he notices his left toe is blackish and extremely painful. On examination, the doctor finds no pulse in the foot, which is cold, numb, and unhealing ulcer on the toe appears gangrenous. Raj undergoes emergency angiography, which reveals complete blockage, compromised blood flow. Attempts to clear the vessel are unsuccessful. Sadly, the gangrene starts spreading despite antibiotics, and the leg has to be amputated below the knee to save Raj's life. Raj is devastated and swears to quit smoking and tightly control his diabetes. In conclusion, diabetic foot disease refers to the wide range of pathologies affecting the foot as a result of diabetes-induced nerve and vessel damage. This leaves diabetics prone to chronic wounds, infection, and gangrene, which may ultimately require amputation. Thus, early intervention on identifying those at risk, patient education, and prompt treatment of emerging complications is key to preventing adverse outcomes like limb loss. With sound preventative strategies and careful monitoring of glycemia, good foot care, and integrated multidisciplinary management, the morbidity and mortality from diabetic foot can be minimized.